Firstly, we'd all like to thank Joint Operations for inviting us to do this afternoon. I'd like to introduce myself. I'm James Stoddard, one of the consultants down in Sheffield. Graeme Hancock is a colleague of mine, and our third colleague, Matt Hampton, who's not here today. And also like to introduce Tim Spalding, who many of you will know, and Bill Bugbee, who many of you will have just listened to. Okay, so we've only got about 25 minutes to get through quite a bit of stuff. Graeme's going to talk to you about what we've set up in Sheffield. We're relatively new to this ourselves, but to give others an insight into what we've been through. Tim will talk to you about his expertise and results of focal resurfacing procedures, and then we've got some case discussions. So I won't keep you any longer. I'll hand over to Graeme to talk you through what we've been doing in Sheffield.
Hi everyone. So what we've been asked to cover really is our early experience of trying to set up a cartilage service in Sheffield, and that basically covers how to set up as a cartilage centre, what our basic algorithm for treatment is, and how we try to manage different sized cartilage lesions, running and building a regional referral process, so getting more referrals into treating these patients, and what our early experience is of outcomes in these patients. So the setup of this is quite complex. Unfortunately, me and Matt, when we started 2 years ago, kind of fell into this scenario where fortunately our predecessor Paul Sutton had done a lot of the legwork for setting up ACI service, because that requires a license from the Human Tissue Authority to allow you to deal with human tissue as it's biopsied at the first stage, and I'm sure many people know. But there's a lot of paperwork that goes with that. There's a lot of collaboration required from many sort of staff members throughout the organisation. There needs to be a designated person who takes charge of the whole process of this and make sure the paperwork is all in order to have HCA oversight. So that's quite involved and requires a lot of involvement. It probably takes a year or two to set up realistically. Running the process itself can be quite challenging. So it's a two-stage process. The time that you normally get the cells back from codon is in the 6 to 7 week region, but it's not defined when you take the biopsy. So there's got to be a bit of flexibility in the system. And that's why the three of us work together, so that there's always availability of one of us to do the second stage procedure when it comes to it. Running this as a single person is basically impossible, because you might be on holiday, you're away at a conference, when the cells become available, and if you're not available to do that, you're wasting your time really. The second stage is also complicated by the fact that when you send your cells away, it's treated under the HTA as human tissue. When it comes back, it's regulated by the MHRA as a drug, and so you've got to have involvement in pharmacy there, so when it comes back, it's make sure it's prescribed. So there's different levels of involvement into the two stages. You've got to have storage in a temperature controlled room, so you've got to have that that set up as well beforehand. You know where it's going, and sometimes that can cause problems if it gets delivered into the wrong place. And then referrals is important. So trying to build and get the word out that what treatment is available, which patients that's for, and getting that around the region so that we get patients in to provide this treatment has been a challenge, but talking at regional meetings has managed to build that, and we're getting actually a lot of referrals from here in North Yorkshire. The ACI is a pretty proven benefit therapy. It's got good outcomes which are maintained. I think we'd probably admit that if we could do as many OCAs as Bill does, then we'd do that. But we don't have the graft availability, so we have to look at alternative treatments to treat these patients. And this is a proven therapy for larger lesions. The commissioning process was that 450 patients a year would have codon therapy in the UK, and only 50 have an OCA. This is slightly historic data, so it was at the point where about 60 and 40 to 50 OCAs were being performed. It's probably more towards 150 codon now, but that's still way below the numbers for the commissioning and what sort of satisfied the quality criteria for using codon in the UK and making it viable. So we need to increase those numbers, and so again, that's widening the scope for referral, making people aware of what the reasons which patients would refer to us. So this was the initial commissioning. So this is only for larger than 2 centimetre squared lesions, and the commissioning policy was that for a chondral lesion, you would treat that with ACI. With an osteochondral lesion, you treat that with OCA. But the importance about ACI is they can't have had any form of cartilage repair previously. So microfracture in particular rules that out as a treatment option. So don't go microfracturing potential lesions, thinking it's potentially you can just do this in the future. Because you can't, it's then completely ruled out as a treatment option. So this is our immediate treatment algorithm. Basically, it's quite straightforward. So smaller, less than 2 centimeter squared lesions, you could potentially argue don't need any treatment. But if you're going to treat them, there's an AMIC variant. By AMIC, that's kind of that sort of Condraguide, which is a joint operations product. But what I really mean when we mean AMIC is chondral patches of all types. Osteochondral lesions smaller than 2 centimeters squared, you could treat with an Oates procedure. And then the larger lesions treated with ACI. In trying to expand the indications for ACI and increase the numbers, we are moving towards what we call a sandwich procedure. So that's bone grafting the defect and then ACI over the top of that. Again, could we do an OCA if we had the graft availability? We'd probably do that, but we don't have that. So we're trying to increase the use of this. Building a service is challenging at times. So both myself and Matt were appointed about 2 years ago. Me with a sort of joint preservation osteotomy type fellowship, and Matt with cartilage experience. And the aim is to build that, and now we provide a joint preservation fellowship encompassing all those aspects. We run a monthly cartilage or complex knee clinic, which is job planned, that two of us are there. It helps with decision making. It becomes a one-stop shop for patients. They come in, all their imaging is either already done or could be done on the day. We can make a decision in that one go, and that allows patients to have met at least two of us. So the chances are that we're doing combined procedures for these. They've met their operating surgeon at least one of before the day. We run an MDT with 6 MSK radiologists, which is important for the MDT approval for these treatments. And then because we work as a 3 and have flexibility where we can move around and we'll each operate on each other's patients, having discussed them all in MDT, this allows us far more flexibility to accept an OCA at short notice. And then we're building physio protocols. Now, these are mainly based on other people's protocols, and so it is a work in progress, but what it allows us to do is send these out with patients to their peripheral centres so they get consistent treatment. In terms of referrals, these were all by letter, but that builds in some delays. You may not have the imaging. You have to go back to patients and say, back to referring centres and say, well, we need some more imaging. That builds in endless delays by sending things by post. So we've moved to an electronic referral process. It allows an immediate response to the referrer, and then we get a far more streamlined service for patients then, and it allows us to track our service and allows us to keep track of PROMS data as well. One of the questions is what can be done in a non-cartilage centre, where you could say really this is the small lesions, but what we do know is if you debride a lesion measured on MR, it's normally 50% bigger than you measured it on MRI scan. So a lot of them end up being larger. So we're happy basically to accept a referral for pretty much any patient you think's got a chondral lesion that might need treatment. And the other argument you might make is if it's really that small, it may not need any treatment whatsoever. The other question is if you're doing those treatments, you might burn the bridge for ACI. But they also, what we know is if you're providing a cartilage treatment for a patient in an overloaded compartment, their alignment's really important. So this is building on the sort of ladder of treatment, really. So if you're then providing a cartilage treatment and they subsequently need an osteotomy, that builds in a lot of time in their rehab. And so you're far better to have simultaneous procedures performed in a single place. So again, we're very happy to answer any questions. If it's purely an osteotomy that someone needs, we have to send them back if you're happy to perform those procedures. I can't stand up here and say we've got loads of data on early outcomes. We're basically 2 years into performing this. The early experience really is that OCAs do amazingly well early on. And like I say, we'd do that all the time probably if we could, but we don't have the graft availability. But this slide just shows that this patient had basically lost his trochlea having fallen off a cliff. And he went from constant pain, loads of stiffness, to a knee that he says is night and day and feels like a normal knee at 2 weeks after an OCA. We know ACI gets better, but it probably takes a year for them to really feel the benefits. So that's all I'm going to say about our practice right now. I'm going to hand over to Tim.
Okay, so I'm going to be talking about the EpiSurf clinical data and experience in this session of the which patient, what treatment and when, and we'll try and get through that because then we've got some cases. I am on the medical advisory board for EpiSurf, and I acknowledge Francesco, who's put together a lot of this data. So what this is an individualized mini implant, and it's based on an MRI scan which you send off to the company, and you get back the patient-specific implant, and then you get the guide that puts it in exactly perpendicular to where it needs to be, along with the instruments. So it's for focal chondral defects. It's been approved by NICE, though insurance companies still argue, and it's not really available for insurance companies. We've got to fight that cause. So for that question of which patient, what treatment and when, it's for this treatment gap, too old for biological and a bit too young for the arthroplasty. But there's very narrow indications for this. There's got to be a good opposite joint surface. So if we're looking at the femoral condyle, you've got to have a normal or very nearly normal tibia. No extrusion of the meniscus, no reduction in the joint's space on the standing x-ray. So it's got very narrow indications for specific focal chondral defects in that age group if we're arguing 40 to 60. Can do it before, can do it afterwards, but that's the indication for it. So the result then, when you have the implant, you have the guide for it, ream out the area, and then insert the mini metal implant to cover that space. And that can be on the femoral condyle or trochlear. So what I want to do is just focusing on the results, looking up the 2-year results of a cohort of patients, and then now the new 5-year results. So this is a multi-center study which we set up with 80 consecutive patients, and you can see the surgeons on the right who have done this, and I know Johannes Holtz is also in the audience listening into this. So this is prospective data collection for the specific indications, and then we collect the outcome scores. So at 2 years, there were 2 revisions, 3 excluded at that point, so we had specific PROMs in 75 of those patients. You can see the demographics there with 60% nearly female and a mean age 48. 65% have had previous treatment, and that'll come relevant when we talk about the factors that can predict outcome. And then lesions on the trochlear, condyle. The twin implant is the sort of double-sized implant compared to the solo implant. The 5-year, this is the new bit then, we've got 10 with missing data, and one of the problems here is in Denmark there are very specific rules on contacting patients for the future, so that means we can only get data out of 6. You're not allowed to contact the patients even by trying to do another consent process. So therefore we've lost 10, and we know they've not been revised, or that's as the best guess, so we haven't got their clinical scores. So withdrawn consent 2, and then failures you've got 11. So 11 revisions, 2 of which were for infection. So that gives a 14% failure rate at the 5-year point. So we have the complete PROMs in 57, and we can provide some basic subgroup analysis, although it's limited by that number. So the headline PROMs are here, and you can see on the left-hand side the Coos score by the domain, with the top line being at the 5-year point. So the scores are maintained, and that's reflected on the visual analog score and on the aggregated Coos 4 score over the 5 years for those where the implant where it's not failed. So rapidly through some subgroup analysis, we want to know, is it worse having a twin rather than a solo implant? No significant difference on the Coos score and the Coos pain score. Same for the condyle against trochlear. Is there going to be one better than the other? There seems to be no significant difference. Same for age, less than 45, over 45. No difference, so that doesn't seem to be a factor in this on the overall Coos 4 and on the pain score. And then we've looked at the medial femoral condyle solo against a twin, against a trochlear, and there again appears to be no significant difference between those. Implant size then, on analysis of that, there doesn't seem to be the observation that a larger implant is going to do worse than a smaller implant. So this is reassuring. The one thing where there is a difference is whether there's been previous cartilage repair. And although it's a significant difference, both groups have improved. Because if you've got a failed microfracture or a failed ACI, then this seems to be a good outcome afterwards. Maybe not as good as the primary indication, but it's still a good improvement. So the analysis of the failures, we've got those 11 failures, 5 gone on to knee replacement, 5 uni knee, and then 1 which is our own patient we bone grafted and did a chondroguide membrane on after taking it out. No one specific cause for that failure, mixture of progression of the arthritis, missed arthritis elsewhere, or just not covering the defect. So indications are important for this. And there is now a revision system where you can take out the implant easily, though it actually does come out pretty easily. So the key results of the summary, it does seem first-line treatment is better than previous cartilage repair, but both improve. And there doesn't seem to be any significant difference in those factors that I've listed. Case example, SONC, excellent case for this, where you can then replace the joint surface and underlying bone. And here's his 43-year-old farmer. You've got a choice to make as to how to manage these. Osteochondral allograft could be an alternative, but he's done that and he's still very happy 7 years down the line. So why do we get these good results? I think the indication is important. You have to have a good opposing joint surface, essentially more than 50% of the meniscus still present, and the size doesn't seem to matter, provided it's covered and it's even. I think the damage marking that you get back is excellent. You send the MRI scan off to Episurf, the company, and then you can play with it, manipulate it, see exactly how it's going to fit. And the instrumentation then allows you to ensure you get the implant in exactly perpendicular to the surface. So you get to play with this online, and you can see from the original scan through to how this should make and where it's going to be recessed. Technique, you have to make it recessed more than about 0.5 of a millimeter so it's not prominent and proud. You get the final design back, so you can see that, and then you get the map you can print out so you know exactly where the guide's going to sit in relation to the trochlear, and it does only sit in one point anyway because it's 3D printed. And then the instrumentation allow you to put it exactly in the right place, covering that symptomatic defect. There has been a consensus document produced. I won't go through that now, but that highlights the same indications that we've said, and that's published 2023. And it does highlight, as my final slide here, this is where we are in 2025. The tight indications. We need a meniscus, you need a good joint surface, need to be well aligned, can do it with osteotomy, of course, and then have had good conservative treatment before. So I think failed previous cartilage repair, this is very much an option, and the trochlear seems to be as good as the condyle. Now this was only a study group on simple one lesion. Of course it's being used in multi-lesion, and there is now going to be a patella replacement, but it's certainly useful for patellofemoral replacement. Kissing lesions, not good. It's got to cover the defect, and you don't want to leave other lesions untreated. So I hope that's given you a power view of the role of the Episurf implant and its indications and results. So with that, we're going to move on to some cases now involving Bill and some discussion, and thank you. So we'll go through the cases.
Yeah. So if we could have the cases loaded up, please. So Graeme and I have just pulled 3 cases of ours over the last few years. What we've tried to do is select 3 cases that brought with them sort of treatment conundrums or discussions or options, and this is probably more of a real world scenario where we get. So the cases should be on the end of the first presentation, please. So the first one, 28-year-old female, atraumatic spontaneous onset of anterior knee pain, been through physio, was referred to us as a small defect within the trochlear. Question of should we be doing something like an OATS, an AMIC, tibial tubercle osteotomy to offload them. So she was seen. This is her MRI. Apologies, it does jump a little bit, but I'll try and stop it at some of the salient slices. So if we look at that, referred as a small defect. Now, this is one of the key points we try and get across to our referring centres, is that what can be perceived as a small defect, initially we see as a much larger defect. And once the surrounding articular surface has been debrided back to what you can perceive as a more normal articular surface, these defects are often a whole lot bigger than is first thought. So, Graeme knows the answer to what we did, but Tim, Bill, what are your thoughts? What would your preference be?
Hello? Can you hear me now? Yeah. So first, like I said, I'd make a clear diagnosis. It is an osteochondral lesion, but that looks like osteochondritis dissecans to me, right? So first you know that. So about 7% in the trochlea, something like that.
Yep.
Then, so now you know the diagnosis, and you know that cartilage repair is going to work in that. And then I want to know what's going on in the patella. That's unclear if the signal changed in the subchondral bone, but that worries me a lot because that's hard. That could be the pain generator. Most of these people have mechanical symptoms, and if it's in the trochlea, pain's optional, but if it's all pain, then I worry about the patella. And then dysplasia. I mean, there's some dysplasia there, which is...
Yep, a degree of, yeah, absolutely.
So you pointed it out, and I pointed it out. Background factors. You got to do all that other stuff before you even consider how to fix that lesion. So, if you're going to do a surface treatment, you're going to have to unload it. If I'm going to do an allograft, I'd probably, this is one, maybe do a TTO depending what the patella. But in this case, I would be getting a patella graft when I was doing my trochlea, just to make sure, or if I could document the patella was okay, or she's had a scope, or she's going to have a scope.
This one is one that's not actually been treated yet, so she's
okay. So
the clinic.
Backing up, this is one where I just mentioned a bunch of unknowns, so this is one where you probably got to get more information before you pull the trigger, right? So
yeah, absolutely.
Step back a bit.
There's a routine that'll get alignment views and things like that, absolutely. Tim, what are your thoughts? What would you think?
I think this is on both surfaces, then the patella and on the trochlea. So isolated cartilage repair on those. Just on the trochlea on one side is not going to work. Your ACI is not going to work.
Yeah.
On that. And the patella does seem laterally tilted.
Yeah. So we did just address that. From my recollection, she wasn't mine. Graeme, just fill us in on exactly what she had a trochlear OCA.
No, she's not been treated yet. This patient.
Oh, she waited.
We're bringing this one more for. Again, the reason for the question. Well, the question on the original referral was, can I do oats to this? It's a small lesion. I think the point is that there's a kissing lesions, and it's probably much larger than you actually think. So, just doing an oats procedure is not really going to work.
So, I guess because you're going to stage her, you're going to scope her, and many people would say, a diagnostic scope unnecessary operation, or are you going to leverage that and do a debridement? And if you're going to do an allograft on that trochlea, if you just drill those cysts, maybe their pain will go away, but the mechanical symptoms won't go away. So I guess everyone would ask, well, if you're already operating, why don't you do the TTO first, get it over with, and see if she's symptom-free? Then you can skip the cartilage repair, save money, and risk for complications.
Yeah.
I think we're heading for...
Okay, thank you very much. So second case is a slight reversal of what we often see. So 27-year-old male, referred with lateral-sided knee pain from a football injury 11 years previous, getting worse over the last 2 to 3 years, and to the extent that he couldn't exercise due to the pain. So you can see the two slices of his MRI. Firstly, the view, obviously the axial view on the left-hand side of the screen, and then the sagittal view on the right. So, we had a plan. The plan slightly changed. Just wondered what... Should we start with you, Tim? What would you consider,
So this
in
is
terms of just the chondral lesion? Yes, there may be a degree of malalignment, there may be a bit of trochlear dysplasia, but in terms of treating that chondral defect, Tim, what would your thoughts be?
This is a osteochondral defect. You can see the fragment there, so there's definitely a loss of the joint surface and the bone. And I think with that size, this is probably 25 millimeters diameter, then this would be an ideal one for me, an osteochondral allograft. Maybe some early debridement to remove any loose fragments, but that would need again to be combined with the patella realignment, tubercle osteotomy, anteromedial to unload it. But for me, best way to treat that would be an OCA.
Can I comment? I think there's a risk of overreading malalignment on MRI. Particularly here, we've got an effusion, the patient's, lying flat in the device. That patella looks pretty normal to me, so I infer the trochlea, which is grown up to match, is probably not that bad. And our data on these isolated trochlea's outcome with an isolated allograft is so good, it's almost better than femoral condyles. And that's because the isolated trochlea has a normal patella. You don't have to worry about that. And we rarely do realignment. I mean, as these guys know, a trochlea allograft for that big lesion is simple, straightforward. Recovery is quick. They're happy, and then you don't have to go through all the pain and suffering of a tubercle osteotomy. So I would do the allograft and not the osteotomy unless I had a compelling reason.
So sorry, Graeme, come in. Yeah, you can come in with what our plan was.
In terms of going back to what I said before, you're trying to expand the indications for ACI due to graft availability. This patient was on the list awaiting ACI as a sandwich procedure, so bone grafting and ACI, not potentially burning the bridge for a future OCA if that was unsuccessful. But their graft became available, and whenever a graft comes offered to us, we search our database, patients waiting, and then subsequently we found that it was suitable. So if you go onto the next slide there, they had exactly what you said, isolated OCA.
But to be fair, I do one thing, and I actually trained to do ACI, but I never did it because everyone wanted an allograft for me. But the data is similar. So if you're an advocate and you're good at ACI, I mean, technically it's a harder operation, right? But now with the scaffold, but still, that you got to know what you're good at. I don't do ACL reconstruction because I'm an arthroplasty surgeon. So if my patient needs an ACL revision, I got to get someone to help me, and I'm fine with that. I know what I'm good at, and I'm really good at allografts. So that makes me tend to do the allograft aside from all the other experiential stuff. But the data in the U.S. for something like this, you get good results with the ACI, and I suppose if further time, just a scaffold with bone marrow under it too. The trouble there, of course, is recreating the anatomy, and that's what's brilliant about an allograft. That was a smaller one, but you can make a whole new trochlea out of an allograft if you want.
Tim, your thoughts?
No, I agree. Osteochondral allograft for that.
Yeah, fine. And then the final case, just quickly, 27-year-old female, and this is really just to highlight the decision-making issues, if you like, which is why we're very involved. Obviously, there's a 3 in Sheffield with the radiologists. A question of when does it become osteochondral, or is it just chondral, and what the thoughts are. Is a little bit of edema allowed? How much edema are you allowed? Should we be thinking about ACI again in a case such as this? I'll try and stop on a good level. That's gone a little bit further past. How much edema do you accept before moving straight to osteochondral, or can you do ACI? Just thoughts of, if we go to you, Tim, first.
What was the previous treatment, sorry?
Not had anything.
No previous treatment. And alignment is good?
Yeah.
I think this is a underlying bone problem as well, that overload, especially the bone edema. So a period of unloading would be good to see how that resolves, and if the articular cartilage is going to survive or not. But once that is resolved, then in theory this should be good for the ACI, the younger patient.
Yeah. I suppose the other consideration, for other centres is that things can change while people are waiting for grafts. We've been very well supported by both Joint Ops and Hospital Innovations in terms of getting grafts to us and accepting them. But things can change. We've had some patients waiting more than 12 months for a graft, and it's trying to convert our experience and experience of others that have done a lot more into real world, almost NHS experience. That's all we've got, but we'd invite any questions from the floor to finish the session.
Can I make a quick comment about this one? Because this is good, because it doesn't fit in a box. That's not OCD, it's not a chondral lesion, and the patient's making cysts. So this is a person that's physiologically got a problem with the subchondral bone. I call it the toothache phenomenon. They got a cavity, and you got to treat the cavity. So the bone extirpation for me is a big deal to get rid of that. And then the final thing is, if you see this and it's been treated by someone and you're not sure why it isn't better, always look on the medial facet of the patella, because everyone misses that lesion, and that mimics medial femoral condyle lesions.
Okay, I think we've got time for one, maybe pushing 2 questions to get me into trouble.
There are microphones.
Thank you for the presentation. Regarding the second case where you showed that you got away with only a trochlear osteochondral allograft, you follow any cutoff where you not do patellar alignment, versus you would have done a patellar realignment in that procedure? Because on the MRI section, it looked like there was slightly increased or lateralized patella, Was it the decision based on TTTG, or how did you go about that decision making?
I think it's just, so again, sort of OCD, no history of patellar instability, so not treated. No.
Just clinical. Right.
But again, offloading, as Bill's talked about there, offloading the patella in particular is always a consideration. Hence, share the pain with your friends and discuss them. And I know patients may find rightly or wrongly that they are consented for different aspects, and different procedures. Should you find intraoperatively, it's not an exact science; it's a judgment, and time will tell, and prove whether our decision making is going the right way or whether we should be rethinking things.
Thank you.
I think we've got time for one last very quick question. Yep. And we're going to be available over lunch for chats and things like that. But yeah, one final question from the back.
Thanks for the talk, really interesting. So how do you manage the sort of logistical time pressures of your fresh OCA, sort of the time that you get it, optimum implantation, and then managing patient availability and list availability?
Yeah, so I think what I was just saying to Boz, who's setting up in Gateshead, is that you've got to work as a team. I think trying to do this as an individual is near on impossible. Trying to get the understanding within the department, within Sheffield Teaching Hospitals, that if these cases, we're a Cartilage centre, so we need to be doing these cases. Like everybody, we've got 1,000,001 knee replacements waiting post-COVID, but it's trying to get that message across that we need to have flexibility within lists to do things. If that's 3 of you, and you've got 3 lists of full-time consultants, you've got more availability. And we found also, the more we say yes to grafts, the more grafts we get offered to us, and the earlier in the lifespan of that graft it comes, which ultimately gives you more flexibility. We found if you say no to grafts and they're being offered elsewhere to other centres first, and then we're getting them at 2.5 weeks, then that obviously makes logistics quite difficult. But it's trying to stay on board ultimately with the managers at the trust that allow us to move patients in at the last minute. But it's having everybody on board, from your waiting list coordinators that we have in Sheffield, to make sure these patients have up-to-date pre-operative assessments. And why that's important: our pre-ops run out at 3 months. There's nothing more frustrating than being offered a graft and finding out on a Tuesday that their pre-op ran out 3 weeks ago.
One more comment, also make sure the patient's available too. We've sort of focused on us, but I found over the years, if you haven't heard from the patient in a couple months, you got to call them up, and you call them, you got a graft. Oh, we're going on holiday, because they're not dying. They've had this problem for a while. So you got to make sure they're on board and how committed they are, and that matters, because people will be there instantly if you tell them, the eager ones, and so you select them on that basis.
Okay. Thank you, everybody. Thank you.